Okay, so let's dive in. The time after having a baby.
Yeah.
It's often pictured as, pure bliss, right?
Yeah, that's the common image.
But the reality for, well, quite a lot of women involves some pretty significant mental health challenges.
Mhm.
And we're not just talking about feeling a bit overwhelmed for a day or two.
No, absolutely not. We're looking at something much more serious, more persistent than the common baby blues.
And understanding that difference, especially when you're revising,
Yeah.
is just crucial, isn't it?
It really is, both for clinical practice and, yeah, for getting these key topics straight for your exams.
Right. So that's exactly what this deep dive is about. We're here to help you get to grips with your own revision notes on postnatal depression or PPD.
Yep, our mission is to unpack this material you've got, pull out the absolute core stuff, the facts you really need to remember, and maybe, find ways to make it all stick a bit better.
Think of us as kind of walking through these notes alongside you, yeah. Pointing out the high-yield bits. PPD is a big deal, affects a lot of women, so getting a solid handle on it is, well, it's essential.
Couldn't agree more. It's so important.
So let's start right at the beginning. What is postnatal depression, according to these notes? They call it a mood disorder affecting women after childbirth.
Sometimes called postpartum depression. And the key things your notes highlight are that persistent sadness, the low mood, things that really get in the way of functioning day to day.
And the timing seems really key here too, doesn't it? The notes say it typically pops up within the first year after birth.
Yeah, often within weeks or months, but, and this is important, it can actually develop later too, even like 6 to 12 months down the line. It's definitely on a spectrum of things that can happen around pregnancy and birth.
Okay, so it's not just the immediate aftermath. And crucially, it's more severe, lasts longer than those baby blues.
Exactly. The baby blues are usually quite mild, self-limiting. PPD is different. Your notes say it affects around 10% of women. And interestingly, there seems to be a peak around 3 months after birth.
That peak at 3 months, that's a good specific detail to lock in for revision. So for the definition, timing within the first year, often weeks, months, peaks at 3 months. And the big difference is persistence and impact on function. That's the key takeaway compared to baby blues.
You got it. That distinction is absolutely fundamental.
Okay, so if that's what it is and when it tends to happen, the big question is why? Why does it develop? The notes admit the exact cause isn't really known. It's complex.
Right, it's not just one thing. They talk about a mix, hormonal factors, biological stuff, psychological aspects, and social influences all playing a part.
Hormones often get mentioned, right? That big drop after birth.
Yes, the rapid decline in estrogen and progesterone is mentioned as a potential factor, but the notes are careful to add a caveat.
Oh,
Yeah, they say the hormonal link isn't actually conclusively proven, so it's likely part of the picture, but maybe not the whole story. The scientific uncertainty is quite interesting.
yeah, it really is. So it's not like a simple cause and effect.
Yeah.
So if the cause is complicated, what makes some women more, well, at risk? What are the risk factors your notes list out?
Okay, this is really important for identification. Several clear risk factors are listed. Having a personal history of depression or other mental illness or a family history of it.
Okay, so past experience matters.
Hugely. And having had PPD before makes you much more likely to get it again than there are stressors.
But what kind of stressors?
Stressful life events, maybe during the pregnancy or after the baby arrives, a difficult or traumatic birth experience itself, and, really importantly, a lack of social support. Feeling isolated.
That makes sense. Anything else on the list?
Yeah. Financial worries, relationship problems are mentioned too. And linking back to the potential causes, those hormonal factors, and of course, major changes in sleep patterns, which, let's be honest, is almost universal with a newborn, they also contribute to the risk.
Okay, that gives us a good framework. Maybe for remembering, you could group them, like history, personal, family, previous PPD, then stressors, life events, birth trauma, money, relationships, and maybe biosport hormones, sleep, lack of support.
That's a great way to think about it. It really emphasizes that it's usually a combination of factors that tips the balance.
Right, it's rarely just one single thing.
Exactly. It's that accumulation of vulnerability.
Okay, moving on to the sort of the mechanics. What's actually going on inside the body, the pathophysiology. The notes are pretty upfront that this isn't fully mapped out either.
No, it's definitely described as a complex interplay. While they can't point to one single trigger, the notes do suggest potential biological mechanisms. Those hormonal changes we mentioned, they come up again.
Right, that rapid drop in estrogen and progesterone post-delivery.
Exactly. It's likely involved, but also there's mention of disruption in mood-regulating neurotransmitters.
Like serotonin.
Serotonin, yes, and dopamine and norepinephrine are the ones specifically listed in your notes. They also mention genetic vulnerability. Some people might just be more predisposed, and an altered stress response system. Plus, those psychosocial factors interacting with all of this.
So it's biological and environmental.
Yeah, the notes even mention genetic and maybe epigenetic factors interacting with stressors, lack of sleep, the general huge adjustment to motherhood, all influencing the symptoms.
Okay, so key terms from the notes for pathophysiology would be things like complex interplay, hormones, those specific neurotransmitters, serotonin, dopamine, or epinephrine, genetics, and the stress response. It's like the whole system is under pressure.
That's a good summary of the picture the notes paint, a system under significant strain from multiple directions.
So if someone presents with symptoms that sound like this, what else might be going on? What are the main things to consider in the differential diagnosis, according to your notes?
Yes, differential diagnosis, crucial for assessment. The notes list several key things to rule out or distinguish from PPD. We've mentioned it already, but the big one is the baby blues.
Right. Need to tell that apart first.
Definitely. Remember, baby blues are milder, shorter-lived. Then you need to think about other psychiatric conditions that could present in this period. Major depressive disorder, because PPD is essentially MDD, just with a postnatal onset.
Okay, so
Okay.
bipolar disorder, generalized anxiety disorder, perhaps an adjustment disorder. And the notes just generally mention other perinatal mental health conditions too.
So for revision, the absolute must-do is separating it from baby blues based on severity and duration, and then being aware of other major conditions like bipolar or significant anxiety that could look similar initially.
Precisely. You need a really thorough assessment to make those distinctions accurately.
Let's talk numbers. How common is PPD? What do these UK-based notes say about the epidemiology?
Okay, the estimated prevalence is generally given as around 10 to 15% of women, which is, quite significant.
1 in 10, 1 in 7, maybe?
Roughly, yeah. But interestingly, the notes also mention prevalence might actually be higher during pregnancy, maybe 12, 13%.
Okay.
And in that first year after birth, some estimates go up to 15, 20%.
Wow, okay. And the notes pointed out a really big challenge with this.
Yes, under recognition. They state that PPD is often missed, and the statistic they give is quite stark. Screening for mental health issues is apparently recorded in only about 13% of patient records.
Only 13%. Seriously.
That's what the notes say. It strongly suggests many cases are slipping through the net. The notes specifically mention potential gaps in general practice and possibly among women from minority ethnic backgrounds whose needs might get overlooked.
That 13% figure really makes you stop and think, doesn't it? It means the actual problem could be even bigger than those 10-15% prevalence figures suggest, just because we're not identifying it effectively.
Exactly.
So key numbers to remember. 10-15% general prevalence, maybe up to 20% in the first year, and that concerningly low 13% recorded screening rate.
Those numbers definitely put the importance of this topic into perspective.
Okay, let's shift from the numbers to the person. What does PPD actually look like? What are the clinical features, the symptoms you'd expect to see or hear about?
Your notes give a really good comprehensive list, and for revision, you can basically think of them as the standard symptoms of depression, but happening in that postnatal context.
Okay, so things like persistent low mood, feeling sad, maybe hopeless, losing interest or pleasure in activities. The notes use the term anhedonia, which is a good one to know, changes in appetite, weight going up or down, sleep problems, though this one's tricky, right?
Yeah, because who doesn't have sleep problems with a new baby? The notes acknowledge that overlap, don't they?
They do. It's about the pattern and severity. What else? Fatigue, really low energy, feelings of guilt or worthlessness, trouble concentrating, being more irritable, more anxious.
And there's a particularly concerning symptom mentioned, too.
Yes, absolutely crucial to pick up on thoughts of self-harm or even thoughts of harming the baby. These are serious red flags.
Definitely. And the notes stress that these symptoms are much more severe and longer lasting than the baby blues, really interfering with daily life and potentially impacting bonding with the baby.
Right. And they also mention why women might not actually tell anyone they're feeling this way.
Yeah, the barriers. Like what?
Fear of being judged, fear of stigma, worries about, custody implications, feeling like a bad mother, sometimes masking symptoms with substance use.
Understanding those reasons for hiding it is so important when you're actually talking to someone, isn't it?
Absolutely. For remembering the symptoms, you could perhaps adapt a mnemonic like SIDGE caps for general depression, but make sure you're tailoring it to the PPD list in your notes. Definitely include irritability, anxiety, and those specific thoughts about harm.
That seems practical. Know the core depression symptoms, but recognize how they show up specifically in this postnatal period, including those really worrying thoughts.
Exactly. It's about context and severity.
So someone comes in, they have these symptoms. How do we actually make the diagnosis? How do we confirm it's PPD, according to the notes?
The notes are really clear on this. The diagnosis is primarily based on a thorough clinical assessment. That means talking to the woman, taking a detailed history, really listening, and evaluating her symptoms against standard diagnostic criteria, like from the DSM-5 or ICD-11.
So no magic blood test or scan.
Correct. The notes explicitly state no specific laboratory or imaging tests for confirmation of PPD itself.
Okay, but they do mention doing some investigations.
Yes, but that's for a different reason. Those tests are about ruling out other medical conditions that could potentially mimic PPD symptoms or be contributing factors.
Okay, like what sort of tests?
The notes list things like thyroid function tests, because thyroid problems can definitely cause mood changes and fatigue. A full blood count to check for anemia, another cause of fatigue. Maybe a urine drug screen if substance use is a concern. Brain scans like CT or MRI are mentioned, but only if there's a specific reason to suspect other brain pathology, definitely not routine.
Right, so diagnosis is clinical first and foremost. Labs are just to exclude other stuff. What about screening tools? They're mentioned, aren't they?
Yes, screening is really important for picking up potential cases early. The notes recommend asking specific questions about mood during antenatal booking appointments and postnatal checks.
Just asking directly.
Yeah, simple questions like, during the past month, have you often been bothered by feeling down, depressed, or hopeless? And during the past month, have you often been bothered by having little interest or pleasure in doing things? And then using validated tools if concerns arise. The Edinburgh Postnatal Depression Scale, the EPDS, is the classic one mentioned.
Okay, EPVS, any others?
PHQ-9 for depression, G87 for anxiety are also listed. And interestingly, they mention the Mood Disorder Questionnaire, the MDQ, specifically for screening for mania or hypomania, reminding us about that bipolar differential again.
Makes sense. And the formal diagnostic criteria.
Requires meeting a threshold. Typically 5 or more core symptoms, one of which must be low mood or anhedonia, present most days for at least 2 weeks. These symptoms need to cause significant distress or impair functioning and can't be better explained by substance use or another medical condition. And this diagnosis applies up to 12 months after delivery.
Got it. So, key points for diagnosis. It's clinical. Labs rule things OT. Screening questions and tools like EPDS are vital. And know the basic criteria: 5+ symptoms, 2 weeks, impairment within that first year.
Excellent summary. That covers the core of the diagnostic process outlined in the notes.
Okay, so we've got the diagnosis. Now what? How do we help? The notes talk about a multifaceted approach.
Yes, it really needs to be tailored to the individual woman and how severe her symptoms are. The main strategies listed fall into a few categories: psychological therapies, support systems, and medication.
What kind of psychological therapies are mentioned specifically?
CBT, cognitive behavioral therapy, and IPT, interpersonal therapy, are highlighted as effective options. Support groups are also really valuable, providing that peer support and sense of community.
And medication.
Yes, for moderate to severe PPD, antidepressants, specifically SSRI, selective serotonin reuptake inhibitors, are a key part of treatment according to the notes.
Are there other types of support mentioned?
Definitely. Supportive interventions are key. Things like providing education about PPD, offering general counseling, helping the woman connect with or strengthen her social support networks. And the notes really emphasize the importance of teamwork midwives, health visitors, GPs, mental health specialists, all potentially involved in communicating.
Right, a team effort. And how does the approach change depending on how severe the PPD is?
The notes lay out a kind of stepped care or tiered approach. For mild to moderate symptoms, the first steps might be things like guided self-help, non-directive counseling, or maybe brief CBT or IPT.
Okay.
But if someone has mild symptoms but also a history of severe depression, the notes suggest considering antidepressants even at that stage. For moderate or severe PPD, the recommendation moves toward high-intensity psychological therapy, like full CBT, starting antidepressants, or often a combination of both.
And the medication choice,
Mm-hmm.
especially if the mother is breastfeeding. That's a huge consideration, right? The notes must cover that.
Absolutely crucial, yes. The notes list specific SSRIs that are generally considered compatible with breastfeeding due to lower levels in breast milk. Sertraline and paroxetine are the main ones mentioned from that class.
Okay, sertraline, paroxetine, any others?
Nortriptyline is also listed, although that's actually a tricyclic antidepressant, TCA.
Right.
But the notes specifically say to avoid fluoxetine and citalopram because they tend to reach higher concentrations in breast milk.
Good to know the ones to avoid, too.
Yes. And generally, other TCAs are used cautiously due to toxicity risks if overdose occurs. Mirtazapine and venlafaxine are mentioned as having less safety data in breastfeeding. Whatever is chosen, monitoring the baby is essential.
What about the really severe cases? Suicidal thoughts? Thoughts of harming the baby?
Urgent psychiatric referral is needed immediately in those situations. The notes state that admission to a specialized mother and baby unit might be necessary to provide intensive care and support for both mother and infant safely.
It sounds like there's also an emphasis in the notes on involving the woman in decisions about her care, being culturally sensitive, and considering the impact on the whole family.
Yes, those are definitely mentioned as important principles underpinning good management. Ensuring the approach fits the individual, adheres to guidelines, and also considers specific groups like adolescents.
Okay, so for a quick management recap for revision, think multifaceted, tailored to severity. The pillars are psychology, CBT, IPT, support groups, networks, meds, SSRIs know the breastfeeding ones like sertraline, paroxetine, and teamwork. And remember, severe symptoms mean urgent referral, possibly to a mother and baby unit.
That's a solid overview of the management strategies described.
So once someone gets treatment, what's the outlook? What's the prognosis generally like for PPD according to the notes?
Generally positive, actually. The notes suggest that with the right treatment and support, symptoms often significantly improve, typically within a few months.
That's good to hear. But what if it's not treated?
Well, that's where the concern lies. Untreated PPD can have really significant, potentially long-lasting negative consequences. The notes emphasize the potential damage to the mother-infant relationship and the possible impact on the child's longer-term emotional and cognitive development.
So that really underlines why spotting it and treating it early is so critical.
Absolutely. It makes a huge difference.
And what about stopping it before it even starts? Can we prevent PPD? What do the notes say about prevention?
The main focus for prevention in these notes seems to be through proactive identification and screening, especially identifying women who are at higher risk.
Like those with a history we talked about.
Exactly. Women with a history of severe mental illness or a strong family history of serious perinatal mental illness. The note suggests referring these high-risk individuals early on to secondary care mental health services for assessment and potential preventative support.
And for everyone else.
Routine screening. The notes highlight the role of all the different healthcare professionals involved, midwives, obstetricians, health visitors, GPs, in asking those screening questions about depression and anxiety at key points, like the booking visit and postnatal checks. Asking specifically about any past or present mental health issues and treatment is vital.
Okay, so prognosis. Generally good with treatment. But untreated, the notes warn of serious long-term effects. And prevention, according to this material, is heavily reliant on screening and early referral for those identified as high risk.
That captures the core messages on outcomes and prevention from the notes, yes.
Right, let's just circle back slightly then and talk specifically about the complications if PPD isn't managed well or isn't treated at all. What are the specific negative outcomes listed in the notes? It builds on what you just said about prognosis.
It does. And the list of complications really hammers home why addressing PPD is so vital. They affect both the mother and the child significantly.
What kind of impact on the mother?
The notes mention difficulty bonding with the baby, which is heartbreaking, impaired maternal-infant attachment, an increased risk of relationship problems like marital conflict, and just a generally reduced quality of life for the mother herself.
And for the child. What are the potential ripple effects?
The notes list potential impairments in the child's cognitive and emotional development. There's also an increased risk of future mental health disorders for the child and for the mother later on.
So it can cast a long shadow.
It really can. The notes mention seeing changes in behavior in children whose mothers had PPD and even a higher risk of them developing depression themselves earlier in life. They also mention postpartum psychosis.
Ah, yes. Is that considered a complication of PPD?
It's mentioned as a potential severe outcome in the postnatal period, but it's generally considered a distinct, though sometimes related, condition. It's much rarer and often linked to underlying conditions like bipolar disorder or schizophrenia. But it's definitely something to be aware of in this context.
Okay, so the complications are widespread. Mother's well-being, relationships, bonding, and profound, potentially lasting effects on the child's development and future mental health. And postpartum psychosis is a separate, severe condition to keep in mind.
Precisely. Understanding those potential outcomes really underscores the importance of effective, timely identification and management. Maybe a memory prompt. Think impacts mother plus impacts child plus related severe condition, psychosis.
Wow. Okay, we have definitely covered a lot of ground there, working through your notes section by section. We've hit the definition, the why and who's at risk, the complex biology, what else it could be, how common it is, the symptoms to look for, including those crucial red flags.
How it's diagnosed clinically, the different ways to manage it depending on severity, thinking about breastfeeding safety, the likely outcomes, the focus on screening for prevention.
And finishing with those really serious complications if it gets missed.
Yeah, but hopefully breaking it down like that, piece by piece, directly following your material, makes those key points feel a bit clearer, a bit more manageable for your revision.
Definitely. Remembering those key differentiators, the risk factor groups, the management pillars, psychology support, meds, team, and just why acting early is so critical. That seems key.
Absolutely. Those are the high-yield takeaways.
So, stepping back from the specific details for a moment, what does thinking about PPD in this depth make you consider? For me, it highlights just how interconnected everything is: physical health after birth, mental well-being, social support, all crucial for both the parent and the baby during such a vulnerable time.
That's a great point. It really underscores the need for holistic care, doesn't it?
It does.
And maybe it raises a bigger question for you to mull over as you continue studying. Beyond the clinical guidelines and the facts in these notes, how can we as a healthcare system, as communities, build better support structures? How can we be more proactive in preventing this kind of distress and actually catching PPD even earlier? Something to think about.
That's a really important question.
Yeah.
Definitely food for thought. Well, we really hope that this deep dive through your revision notes has been genuinely useful for you.
Yeah, hope it helps it all sink in.
And just a reminder, you can find more resources for this kind of revision material over at Pathophysiology.com.
And also at freemsra.com.
So thank you for joining us for this deep dive into postnatal depression.